Now coming to another important complication in thoracic surgery is the pulmonary hypertension. Pulmonary hypertension is defined as the mean pulmonary artery pressure greater than 25 millimeter of mercury or a systolic pulmonary artery pressure greater than 35 millimeter of mercury. It is usually present in pulmonary resection for benign or malignant lesion, esophageal surgery or vascular surgery. There is increased risk of respiratory complication and need for prolonged intubation in patients with pulmonary hypertension who come for non-cardiac surgery. There are usually 5 major diagnostic groups in the classification of pulmonary hypertension with multiple subgroups. But what is very important for anesthesiologists is 2 main types. One due to left heart disease, another one due to lung disease. Whether it is due to the heart or the lung, that is very important for us. Most of the anesthesia literature are focused on the pulmonary hypertension due to cardiac disease. But the patient who are coming for non-cardiac surgery particularly have pulmonary artery hypertension secondary to lung disease. That is very important. The prevalence of pulmonary hypertension in severe lung disease is around 40 to 50%. You have to understand that. Now coming to the classification of pulmonary hypertension, there are 5 major groups as I said earlier. Group 1 is actually the pulmonary artery hypertension. Here you have the hypertension in the pulmonary artery where most of the time it is due to idiopathic. You don't know the cause, but still the pulmonary artery pressures are very high. Group 2 is the pulmonary artery hypertension which comes from the left side of the heart, either ischemic heart disease or valvular heart disease. Group 3 is the pulmonary artery hypertension due to lung disorder. Group 4 is pulmonary artery hypertension due to chronic thromboembolism. And group 5 is unclear multifactorial mechanism like sarcoidosis and hematological disorder. Here you can see the pulmonary artery hypertension secondary to coronary artery disease, which is very common. Here you can see the apical part is not moving and patient had LAD ischemia. And if you look at the pulmonary artery pressure which was normal due to ischemia, it has increased drastically. And as the pulmonary artery pressure increases, you can see the ectopic happen. So this is purely pulmonary artery hypertension due to left heart disease which stands from ischemia. Now coming to pulmonary artery hypertension due to lung disease, here you can see a normal PA pressure. The yellow one is the PA pressure 22:1 and the pressures are normal. And here what I am trying to do is I am trying to occlude the lung. This is double lumen tube. So I am trying to compromise the left lung. As I clamp the left lung, here you can see the pulmonary artery pressure increases and the saturation which was 100 following occlusion, here you can see the saturation slowly comes down. And here once the left sided is occluded, you can see the saturation has come down, which was 100, the saturation has come down and the PA pressure which was around 22 has gone to almost 30/12. You can see the pulmonary artery pressure going up and the saturation coming down. That happens with lung disease. As you occlude the ventilation to the left lung, here you can see the pulmonary artery pressure going up and the saturation coming down.